If an adult grew at the exact same velocity as an infant in their first year of life, you would weigh over 400 pounds.
Oh my gosh.
Right. And your skull would be like the size of an actual watermelon by your next birthday.
It is such a terrifying visual, but the math completely checks out.
It's insane.
It really is. I mean, the sheer biological energy required to pull off that kind of physical transformation is just staggering.
You know, usually when we talk about nursing adult patients, there is this expectation of a sort of static baseline.
Right.
Like you are maintaining a completed machine. You check the vitals, you look at the labs, and you are comparing them to this fixed set of adult parameters.
Exactly. The engine is built, so you're really just changing the oil.
Yeah. The foundation is poured, the house is built. You're mostly just dealing with daily maintenance.
Or repairing things when they inevitably break down.
Right. But then you step into the pediatric ward, and suddenly that house is actively adding rooms.
Yeah.
It's like changing the plumbing and rewiring the electrical system all at the exact same time.
Which is incredibly chaotic.
It is. You aren't just looking at a patient. You are tracking a rapidly moving target.
It is the absolute definition of a dynamic landscape. I mean, in pediatric nursing, you aren't just caring for, quote-unquote, little adults.
Right.
Their physiological needs, their vital signs, their cognitive abilities, they vary wildly based on their developmental level.
Which changes month by month.
Exactly. Knowing what is normal at every single age is literally the only way a nurse can spot the abnormal.
Because if you don't know the baseline of the construction phase,
You cannot possibly spot a developmental red flag. It's that simple.
which brings us to our mission today. So if you are listening to this deep dive, chances are you are a hardworking BSN nursing student.
Yep.
Maybe you're gearing up for your pediatric nursing course or, getting ready to step onto the floor for your clinicals.
It's a big moment.
Yeah. So today we are going to dive into one of the most heavily tested and frankly clinically vital areas of pediatrics.
Expected growth and developmental milestones.
Yes. From a newborn infant all the way through adolescence. Okay, let's unpack this.
All right, so we have to start at the very beginning with infancy, obviously. So birth to 12 months.
The explosive phase.
Right. What is fascinating here is the sheer velocity of change we just mentioned. The first year is marked by the most explosive physical and motor growth a human being will ever experience.
Well, let's talk about those golden rules of infant weight because you will absolutely see this on your exams.
Oh, guaranteed.
Yeah. The standard expectation is that a baby's birth weight should double by 6 months.
Right.
And it should triple by 1 year.
Spot on. And it's not just overall body mass, right? It is critical cranial development.
Oh, the skull.
Yeah. An infant skull isn't fully fused. It has fontanelles or soft spots.
Right, to allow for that massive brain growth.
Exactly. The brain literally triples in weight during this early period.
Wow.
So it needs physical room to expand without compressing the actual brain tissue.
So that dictates the timeline, right? Like the posterior fontanelle, the smaller one at the back of the head, that closes at 2 to 3 months of age.
Correct.
But the anterior fontanelle, that sort of diamond-shaped larger one on top.
The main one, yeah.
That stays open much longer. That closes between 12 and 18 months.
And as a nurse, you are assessing those soft spots at every single infant encounter.
It's mandatory.
Completely. They are a literal window into the patient's hydration and neurological status.
Because if it's bulging...
A bulging anterior fontanelle could mean increased intracranial pressure.
Right.
So maybe from meningitis or hydrocephalus.
Yeah.
But a sunken one? That's a blazing red flag for severe dehydration.
Which totally changes how you think about toddler falls, too.
Oh,
Because for 1.5 years, that baby's brain is essentially vulnerable just beneath the scalp.
it's stressful.
It really is. And while we are talking about the head, we can't forget teething. Teeth generally erupt around 6 months of age. And by the time that infant reaches their first birthday, you should expect to see about 6 to 8 baby teeth.
Which brings a whole host of secondary issues that parents will ask you about.
Like the drooling.
The drooling, low-grade fevers, fussiness. But the most visible transformation in that first year is their movement.
Yes. When it comes to motor skills, I always used to think of it like downloading an operating system onto a brand new computer.
Okay, I like that.
Right. You install the basic hardware drivers before you can run the complex apps.
Yeah.
But biologically, it's actually much cooler than that. The medical term is the cephalocaudal trend.
Which is highly testable.
Very. So if we break down the Latin, cephalo means head and caudal means tail. So development happens from the head down to the toes.
And the mechanism behind that is myelin.
The fatty sheath.
Exactly.
Yeah.
Myelin is the sheath that insulates the nerves. In a newborn, the nervous system is basically just a house full of uninsulated wires.
That sounds dangerous.
Well, it's just very uncoordinated. As the baby grows, the body actively lays down that myelin sheath, starting from the brain and working its way down the spinal cord.
Oh, that makes so much sense.
Right.
That's why a baby can control its neck muscles long before it can control its knees.
Yep. The insulation hasn't reached the legs yet.
Wow.
You see this progression beautifully in clinical assessments. Like at 1 month old, the baby just has a strong grasp reflex and significant head lag when you pull them up by their arms.
Because the cervical hardware is barely online.
Exactly. But by 4 months, that myelin has reached the upper spine. The head lag is completely gone.
Okay.
And they are grasping objects intentionally with both hands.
Let's talk about clinical red flags for a second here. Because if a nursing student is doing a well child check on a 6-month-old, and that baby still has significant head lag,
that is a massive clinical warning sign.
Right.
Failing to meet that milestone suggests the neurological wiring just isn't progressing.
So it's not just a delay, it's a structural issue.
Exactly. A persistent head lag at 6 months is a major red flag for cerebral palsy or other neuromotor delays.
You would immediately flag that for the provider.
100%.
Okay, and then we get to the rolling rules. And I always struggle to remember the exact order of this.
It can be tricky.
Let me see if I have this right for the exams. So at 4 months, the infant rolls from side to side.
Right.
At 5 months, they roll from front to back.
Yep.
And at 6 months, they can finally roll from back to front. But wait, why does front to back happen first?
It seems backwards.
Yeah, I would think going from the back to the stomach would be easier.
It actually comes down to leverage and upper body strength.
Okay.
At 5 months, when they're doing tummy time, they can push up on their arms.
Oh, so they're already elevated.
Right. They naturally shift their weight, they lose their balance, and gravity does the rest. They just flop over from front to back.
Oh, that's hilarious. So it's basically a controlled fall.
Pretty much. It takes far more deliberate core strength and hip rotation to initiate a roll from a flat back onto the stomach.
Which is why that final back-to-front maneuver isn't mastered until 6 months.
Exactly. It's a step-by-step unlock.
And once they can roll, the gross motor skills just snowball, right? Because that myelin sheath is traveling further down the spine.
Yeah, it speeds up. By 8 months, they are sitting completely unsupported. At 9 months, the insulation has reached the lower body. So they are pulling themselves up to a standing position and creeping on their hands and knees.
And then by 11 months, they're doing what we call cruising.
Yes.
Which means they're walking sideways while holding on to furniture.
And then the big one. At 12 months, they can walk with one hand held, or even take like 2 to 3 independent steps.
So the cephalocaudal journey is essentially complete.
Basically, yes.
And while that gross motor progression is happening, the fine motor skills are getting, precisely calibrated.
Oh, yeah.
Like at 8 months, they begin using a pincer grasp, bringing the thumb and index finger together.
And by 9 months, it's a crude pincer grasp.
Right.
And you will actually start to see their dominant hand preference becoming evident.
Really? That early?
Yeah. The neurological coordination between the visual cortex and the motor cortex is locking in.
And by 11 months, that becomes a neat pincer grasp. So they aren't just awkwardly palming things anymore.
Right. They have the dexterity to deliberately pick up a tiny piece of cereal and place it into a container.
Which is wild. And if we connect this to the bigger picture, all of this physical exploration is driving their cognitive and social development too.
Completely intertwined.
According to Erikson's psychosocial theory, infancy is the stage of trust versus mistrust.
Which isn't just an abstract theory, by the way. This is actively happening on the floor.
How so?
Well, when a nurse or a caregiver responds reliably to an infant's needs, feeding, changing, or comforting them when they cry, that infant learns the world is safe.
So if you let an infant cry it out in a hospital crib because you think they need to, learn independence...
You are actively disrupting their psychological development of trust.
Wow. And cognitively, Piaget places them in the sensoromotor stage.
Right.
So they are learning entirely through reflexive physical interaction with their environment.
Which perfectly explains their social milestones. Like at 4 months, separation anxiety can begin.
Because they realize they are a separate entity from their caregiver.
Exactly. By 6 months, They develop a fear of strangers.
Oh, yeah.
They can clearly recognize familiar faces, and they know who isn't one of them.
And their communication is evolving right alongside this, right?
Oh, absolutely.
By 9 months, they are saying dada and mama, and they respond to their own name.
Yep.
By 10 months, they can comprehend the word no and obey single commands if you use gestures.
So in just 12 months, we have gone from a reflexive, head-lagging newborn
To a cruising, babbling little human who knows their name and can put a toy in a box.
It's incredible.
Here's where it gets really interesting.
Oh, yeah.
Once they can move entirely on their own, the mission completely changes. They graduate from infants into toddlers.
Which covers toddlers, age 1 to 3 years, and preschoolers, age 3 to 6 years.
The focus shifts entirely from installing that basic physical hardware to, like, executing complex interactions.
And demanding autonomy.
Yes. They are the movers and shakers of the pediatric ward.
They really are.
So let's look at the toddler motor leaps. At 15 months, they are walking without help.
Mm-hmm.
And fine motor-wise, they can build a tower out of 2 blocks. But I have to ask, why are block towers always on the nursing exams?
I know, it seems so random, right?
Yeah, like why blocks?
Because building a block tower requires an incredibly complex sequence of neurological events.
Really?
Yeah. It tests spatial awareness, hand-eye coordination, and crucially, voluntary fine motor release.
Oh, letting go.
Right. Picking up a block is easy. Deliberately letting go of it at the exact right moment so it balances on another block. That is a massive neuromotor milestone.
Wow, that actually makes so much sense.
Yep.
And just 3 months later, at 18 months, they are running, albeit clumsily and falling often.
Very clumsily.
They can turn the pages of a board book, usually 2 or 3 pages at a time, and that block tower grows to 3 or 4 blocks.
Stairs are another major clinical marker here.
Oh, true.
At 2 years old, they can walk up and down stairs. But the key detail is they do it by placing both feet on each individual step before moving to the next one.
Okay, so they haven't mastered alternating their feet yet.
Precisely. Because alternating feet requires the brain to rapidly shift the body's center of gravity from one side to the other.
While moving vertically.
Exactly. The neuromotor mapping for that balance takes another full year to develop.
Man, the body is so cool. So as they transition into the preschool years, ages 3 to 6, those movements become incredibly refined.
They do.
At 3 years old, they graduate to playing on a riding toy, like a tricycle.
Yep.
They can jump. And their block tower is now 6 or more blocks high.
By 4 years old, the fine motor skills are getting serious.
Like using scissors.
Yes. Safely using scissors, they can draw a square, and they can skip and hop on one foot.
And by 5, we are looking at a huge leap in independence. They can dress themselves, learn to tie their shoes, draw a triangle, jump rope, and ride a 2-wheeled bike.
It's a lot of physical activity.
Which makes me wonder, with all this physical energy being expended, how does language even keep pace?
Well, we call it the snowball effect of language.
Okay.
The receptive language, meaning what they understand, always outpaces their expressive language,
Right.
which is what they can say.
Right.
That gap is actually what causes most toddler tantrums.
Oh, because they know what they want but lack the vocabulary to express it.
Exactly. It's incredibly frustrating for them. At 18 months, a toddler knows about 50 words.
Okay.
By age 2, they are forming multi-word sentences, usually combining 2 to 3 words.
And by age 3, they're combining several words to create simple sentences using actual grammatical rules, like they start using I, me, and you.
And it just accelerates from there. By 4, they are using 4 to 5-word sentences and can count to 10 by rote.
And by 5, they are actively telling stories using the future tense, and they can even state their full name and address.
Psychosocially, this area is a minefield if you don't know what you're doing clinically.
Seriously. For toddlers, Erickson calls this autonomy versus shame and doubt.
Right. They are trying to assert control over their bodies. Think toilet training and dressing.
So if you scold a 2-year-old for wetting the bed in the hospital,
You aren't just making them sad. You're actively inducing shame and disrupting their psychological development of autonomy.
that is such a crucial takeaway. And for preschoolers, it evolves into initiative versus guilt.
Yep.
They are actively exploring, playing, and asserting power over their environment.
So when you see a 4-year-old insisting on pouring their own juice and making a huge mess.
That is them navigating this exact developmental crisis.
Exactly. As a nurse, you have to facilitate that autonomy where you can.
Right.
Let them take off their own adhesive bandage. Let them choose between the red cup or the blue cup for their oral medication.
Offering them controlled choices makes a world of difference in their compliance.
And their emotional well-being.
Absolutely. Now, we just saw toddlers and preschoolers burning massive calories to walk, run, and assert their independence.
Yeah.
But suddenly, around age 6, that physical growth curve flattens out.
It really does.
The caloric requirements actually decrease compared to the previous stages. Where does all that biological energy go?
It routes directly to the brain and to social integration.
Ah.
This is the school age period, from 6 to 12 years old. Because the body puts physical growth on a steady cruise control, the child can pour all their developmental energy into complex thought and peer relationships.
And play completely transforms here, doesn't it?
Oh, night and day.
Up until now, play was often parallel, like toddlers playing next to each other with their own toys but not really with each other.
Right.
But in the school-age years, cooperative and competitive play become predominant.
Between ages 6 and 9, you see them playing simple board games, number games, hopscotch, jump rope.
And they become obsessed with collecting things.
Completely. Rocks, trading cards, plushies, you name it, they will categorize it and trade it.
And then from ages 9 to 12, the shift moves toward more complex tasks.
Yeah.
They are making crafts, building intricate models, solving jigsaw puzzles, and joining organized competitive sports.
Cognitively, this lines up perfectly with Piaget's concrete operational stage, which hits right around 7 to 11 years old.
And this is a huge milestone because they finally master the concept of conservation.
Yes.
Conservation is such a brilliant concept. I always nerd out over the water glass experiment.
It's a classic for a reason.
Right. So before this stage, if you poured the exact same amount of water from a short, wide glass into a tall, skinny glass, a preschooler would insist the tall glass had more water.
Because they can only focus on one variable at a time, the height.
Exactly. But in the concrete operational stage, they understand that the volume stays the same despite the change in shape.
The mental RAM, required to hold two variables, height and width, in their working memory simultaneously, is a massive neurological leap.
It's huge.
They can also tell time, solve concrete math problems, and critically, they can finally see the perspective of others.
And that perspective shift is so important for Erikson's psychosocial stage here. Industry versus inferiority. These kids are suddenly coping with intense new social and academic demands.
When they succeed at a board game or, finish a model airplane or pass a math test.
It leads to a profound sense of competence in industry.
Exactly. But if they constantly fail or are overly criticized, it results in lingering feelings of inferiority.
Which dictates a major clinical counseling role for nurses.
It really does.
Because this age group is so focused on social integration and digital interaction, nurses have to educate families on holistic health.
Especially with that decreased caloric need we mentioned earlier.
Right.
School-age kids are at a higher risk for obesity if they remain sedentary.
They absolutely need at least 1 hour of physical activity daily. Bike riding, sports, playground time.
And part of that counseling is educating families to strictly limit screen time to 2 hours a day.
You are tying those developmental milestones directly to their overall health outcomes.
But, as we know, that steady, predictable school-age cruise control does not last forever.
No, it doesn't.
Eventually, that stability is completely shattered.
The biological earthquake. We
Yeah.
are talking about adolescents, ages 12 to 18 years. This stage is entirely about maturation, hormonal surges, and identity formation.
The hallmark of early adolescence is, of course, puberty.
And as a nursing student, you must know the exact sequence of these physiological changes.
Yes, memorizing the order of maturation is a classic nursing exam hurdle.
I have the female sequence down.
Okay, let's hear it.
It begins with breast development. This is followed by pubic hair growth, though sometimes the adrenal hormones kick in early, meaning pubic hair growth can actually precede breast development.
Right, that happens.
Next is the growth of axillary, or underarm, hair. And the final step in the sequence is menstruation.
That is exactly correct. The gonadal hormones generally drive the breast development, while adrenal androgens drive the hair growth.
Which is why there can be slight variations.
Right. But the standard testable sequence is breasts, pubic hair, axillary hair, menstruation.
Okay, but the male sequence always tricks me up.
It's a bit longer.
Because the primary sex characteristic changes happen before the visible secondary ones, right? Like testicular enlargement kicks it off, not hair growth.
Exactly. The gonadal hormones have to stimulate the primary organs before the secondary hair follicles react.
Okay.
For males, the sequence starts with testicular enlargement. That is followed by pubic hair growth.
Then penile enlargement.
Yes. After that, we see the growth of axillary hair, followed by facial hair growth.
And the final major physical change is vocal changes as the larynx enlarges.
You got it.
It is a total systemic overhaul. And while their bodies are transforming, their brains are making the final leap in Piaget's cognitive stages.
Right, entering the formal operational stage around age 11 and up.
This is a profound shift. For the first time, they possess the ability to think abstractly and hypothetically.
They don't just solve problems directly in front of them anymore.
Right.
They can evaluate the quality of their own thinking, they can maintain attention longer, and look far beyond their current circumstances into the future.
At the same time, they are navigating Erickson's stage of identity versus role confusion.
Yes.
They are desperately trying to develop a unique sense of self and personal identity independent of their parents.
They rely heavily on their peer group to figure out who they are.
Which brings us to a really crucial clinical application.
Extremely crucial.
As a nurse, you are dealing with a patient who can think abstractly and process complex medical information. But their prefrontal cortex, the logic and consequence center of the brain, is still lagging behind their amygdala, which is the emotional center.
So they're still developmentally immature when it comes to long-term decision-making and peer influence.
Exactly. You can't talk to them like toddlers, but you also can't treat them like 40-year-olds. So clinically, how do we handle that?
Well, you must address the adolescent's concerns directly. Don't just talk to their parents while the patient is sitting right there.
Oh, that's a big one.
Inform the adolescent of your actions and explain the rationales behind them. They have the cognitive ability to understand the why, and they demand that respect.
And above all else, respect their privacy.
Yes.
Give them the option to have their parents step out of the room for the assessment. And when performing a physical, always examine the genitals last to minimize embarrassment and anxiety.
You are honoring their developmental need for respect, autonomy, and identity validation.
So, what does this all mean? If you are that BSN student listening to this on your commute or during a study break, why go through this entire timeline?
Right.
Mastering these milestones, from knowing that a 6-month-old rolling back to front requires myelination, to understanding why a 2-year-old needs to pour their own juice, to memorizing the exact pubertal sequence of a teenager.
It is your ultimate toolkit.
It really is. It is the only way you can provide truly developmentally appropriate care.
It's important to remember that every single time you walk into a pediatric patient's room, you aren't just checking vitals or administering medication.
Yep.
You are actively evaluating a child's progress on the most incredible, complex timeline in nature, human development.
And before we wrap up this deep dive, I want to leave you with a final thought to mull over.
Okay.
We have talked a lot today about how physical milestones like the fontanelle's closing or the eruption of teeth are deeply hardwired into our biology.
Yeah.
But cognitive and social milestones are influenced by interaction.
True.
As our environment changes, like the modern introduction of constant screen time, algorithmic videos, and digital interactions replacing some of that physical play.
Yeah, that's a huge shift.
How might Piaget's cognitive milestones or Erickson's social stages shift for the next generation of infants and toddlers you will be treating in your clinical practice?
Are we looking at a future where the human operating system gets an entirely different kind of software update?
Exactly. It's wild to think about.
It is a fascinating question, and one you will likely be observing firsthand on the floor in the years to come.
Keep that in mind next time you see a toddler swiping a screen instead of stacking blocks. Good luck on your exams and trust your training.